In this section, we're going to talk about a variety of renal disorders. So our objectives are to review renal anatomy and physiology, look at renal blood flow regulation, and then discuss some common renal abnormalities that happen. So you remember the structure of the kidney. The one reason I like this picture is because it shows the pelvis. We talk about the renal pelvis sometimes, so that's this central area here. And then the cortex is around it. And the cortex is made up of nephrons. And the nephrons are the factories of the kidneys. They're the action, where the action happens. And I like this picture because it shows this larger tube here with the arrows in it is the renal tubule. And then what you see here is that it's surrounded by all these capillaries. So the blood vessels are just right next to the renal tubule. And you have millions of nephrons, so that's happening all through your kidneys. And it's the movement of things in and out of the blood vessels there that determines what's going to be excreted from us. So there's three processes that happen in the kidneys. Oh, my little arrows went, no, I went the wrong direction. There we go. The first one is filtration. So filtration happens at the glomerulus, and everything that goes through the bloodstream ends up going by a glomerulus and potentially could be filtered. Now, is everything filtered at the glomerulus? No. What's not filtered? Large molecules like proteins, red blood cells. Those don't usually appear in the urine, right? They're not filtered. Everything else, or most everything else, is filtered. Water, waste products, byproducts of medications, electrolytes, all those substances are filtered. Now, does everything that's filtered stay in the renal tubule? No. Some of it is reabsorbed. So reabsorption is the movement of substances from the renal tubule back into the bloodstream. So a lot of things are reabsorbed. One of the big ones that we think of is glucose. So glucose is filtered, but usually we don't have glucose in our urine, right? That's because it's reabsorbed. Now in diabetics, when your blood sugar level, your bloodstream level of glucose gets over about 180 or 200 or so, it overwhelms the ability of the kidneys to reabsorb it, and so glucose begins to appear in the urine. And some of you might be old enough to remember in the olden days when we actually checked diabetics' blood or urine for glucose, and that's how we could tell if their blood sugar was too high, because they started to have glucose in their urine. Then we got chem strips and said, let's quit messing with urine and let's just poke them and check their blood. But okay, now, so we have filtration, movement of stuff across the glomerulus, reabsorption, and opportunity to get things back from the renal tubule back into the bloodstream. And then one last chance to look at the bloodstream and say, wait, we still have too much of this, let's put it back in the renal tubule. And that's secretion. So secretion is a chance to get stuff back from the bloodstream back into the renal tubule where it could end up in the urine. And what appears in the urine is the net effect of those three processes. Now, the only reason to show you this is just to show where some of these things happen. I'm not going to ask you which part of the renal tubule these things happen in. But for example, so we know filtration happens at the glomerulus. Here we see reabsorption of all of these things: sodium chloride, glucose, potassium, amino acids, bicarb, phosphates, protein, urea, and secretion of hydrogen ion, foreign substances, organic anions, organic cations. Then in the loop of Henle, we get concentration of the urine, we get water reabsorption, sodium reabsorption, and so on. In the distal tubule, reabsorption of some more substances as well as secretion of some more substances. And then finally in the connecting duct, some more reabsorption, some more secretion, and then whatever's left after all that is going to be what's in the urine. So it's a continuous process going on of shifting back and forth between the blood vessel and the renal tubule. Here's just another picture that's showing what's happening in that cortex up in the top layer here. That's where the glomerulus is, Bowman's capsule. And then we've got the loop of Henle that dips down into the inner medulla and so on, so the various sections of the tubule there. Now, one of the things that we look at is what's controlling blood flow into the kidneys, and it's a process called autoregulation, at least one of the pieces of that. And that means that those blood vessels that are going into and away from the kidney can contract and dilate depending on what's needed to get more blood flow there or less blood flow there. That flow of blood to the kidneys is also determined by the sympathetic nervous system and affected by what the blood pressure is. And then hormones also control that. Again, the renin-angiotensin-aldosterone system controls it, and ANP or BNP, those are just two different forms of the same hormone. We've been talking about BNP, but ANP is essentially the same thing. Also regulates to a certain extent what happens. So the renin-angiotensin-aldosterone system, we've mentioned a little bit. So renin is a substance that's normally stored in the kidneys, in the juxtaglomerular apparatus. And when we need to retain fluid or sodium, renin gets released from the kidneys. So if we have decreased blood pressure, we have less stretch of those juxtaglomerular apparatus cells. Or if we have decreased sodium chloride concentration, so if the bloodstream is more dilute, or if we have beta adrenergic receptor stimulation, sympathetic nervous system stimulation, all of those cause more renin to be released. And renin changes angiotensinogen into angiotensin 1. And then angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzymes. So you all know we talk about ACE inhibitors, angiotensin converting enzyme inhibitors. Well, here's the angiotensin converting enzyme itself. And angiotensin 2 stimulates aldosterone secretion and also causes significant amounts of vasoconstriction. When we have release of aldosterone, that also is a vasopressor, constricts blood vessels. It inhibits further renin release, but it promotes sodium and water retention and excretion of potassium. So when we need this system, it's great because it increases our volume and builds us back up. So if we're hemorrhaging or if we're very fluid deficit, this is great. But it gets activated at times that we don't want it, and then it causes problems. And two big times when that happens are heart failure and hypertension. So if it's working right, it helps us manage our blood pressure, keeps our blood pressure up if we're losing pressure. It retains our extracellular volume, promotes sodium reabsorption and vasoconstriction, stimulates the sympathetic nervous system, and also helps stimulate thirst so that if we're volume depleted, we get that thirst mechanism as well. So here's the picture of it. So we start with angiotensinogen that's circulating in our bloodstream. Renin from the kidneys acts on that to change it to angiotensin 1. Angiotensin converting enzyme acts on that to change it to angiotensin 2. We get release of vasoconstriction and release of aldosterone, which causes sodium and water retention and increased blood volume. So if you're hemorrhaging, this is a wonderful thing. If you're not, it can get us into trouble. Just a word about aging body systems and how kidneys are particularly affected by this. We actually have a decrease in kidney size as we age, a decrease in renal blood flow, and also glomerular filtration rate. We lose nephrons. Our glomerular capillaries atrophy, so we have often capillary changes, blood vessel changes throughout the body with aging, but so we see that in the kidneys as well. Less effective transport in those renal tubules, and then increased bladder symptoms like urgency, frequency, and nocturia. The bladder loses its early warning system, and so when the bladder is full, you got to urinate right now. There's no delay time like you and I have where you get a signal that you have to go to the bathroom. You might be able to wait several hours. If you're a nurse, you wait 12 hours. But when you're older, you lose that, and when you have to go to the bathroom, you have to go to the bathroom right now. You don't have a choice about that, it just happens. Your bladder muscle is less effective, so you have smaller capacity, all kinds of things happen. Okay. Yeah, let's all relax for a minute here. All right, let's talk about urinary obstructions a little bit. There's a lot of things that can cause this. We can have anatomic problems, obstructive uropathy, and we'll talk about stones and how they block the urinary system. And how bad that is just depends on what's involved, how large the obstruction is, if it's something that's obstructing both kidneys or just one, how long it's been going on. When we have urinary blockage, though, we can get hydroureter, which is back of fluid into the ureter. I have a picture of this. And hydronephrosis, which is back of fluid into the kidney itself. Tubulointerstitial fibrosis, fibrosis of the tissue so that it ceases to function. If you have pulmonary fibrosis, you know, your lung tissue changes. We talk about liver fibrosis, same thing, only now in the kidneys. And triggering of apoptosis, so we actually have death of cells if the obstruction is bad enough and prolonged enough. So there's a lot of things going on in this picture, but on the right-hand ureter, this is hydroureter, where we have an enlarged ureter compared to the left ureter. Now it's showing some other things too, some strictures and so on, but the enlarged ureter. And then hydronephrosis is the accumulation of the fluid in the kidney. How old is Mick Jagger? Isn't he like 70 or something? 60? Oh, my goodness. Oh, Ringo Starr just turned 70. Man, whew, that's a little scary. Okay, upper urinary tract obstruction. So talking just a little bit about kidney stones or calculi. So that's just an accumulation of usually minerals that precipitate in the urinary tract and clump together to cause stones. And they're classified according to what they're made up of, because different components can cause different kinds of stones. We can get too much of one or more of those minerals, or we can have a deficiency of substances that normally are present that inhibit stone formation. So normally we have things in our body that inhibit stones from forming, but if we're deficient in those, then stones could form. About 1 million people annually get stones, and there's a 50% recurrence rate within 5 years. So once you get stones, there's a high chance that they're coming back, which is not a good thought for people that have had stones. Most of them contain calcium. They're also uric acid stones that we see especially in cancers and in people with gout. Struvite stones are associated with infection, and cystine stones are a particular inherited defect that happens. So we see renal colic. That's wave-like pain that happens as the stone moves. So there may be no pain when the stone is in the kidney, and then when it moves through that little tiny ureter, there's a lot of pain as it moves through depending on the size of it. When it gets to the bladder again, there may not be any pain, and if it passes on its own and gets through the urethra, then there can be more pain again when it goes through that little tiny urethra. So it just depends on where it's located. And you get to a certain size and it's not going to pass no matter what you do, and then we're going to need to do some kind of intervention. Now, if we can get the stone, if the patient excretes the stone, we could send it for analysis and find out what composition it was, because that will impact what kind of dietary restrictions the patient might be on. Or if we can break it up and have them pass the stone fragments, if we can catch those, we can send them for analysis as well. Doing an IVP can help show where the stones are, because that's, you know, injection of dye. So that we can see the urinary system, not the bloodstream, but the actual urinary structures. So if there's a blockage, we're going to have urine flowing through one ureter, and then it's not going to be flowing any further, so we know there's something there. Or a CT scan, and some stones will show up on an ultrasound, but not all. It depends on the composition of it. And then the treatment would be to remove it somehow, and we do that with lithotripsy, sound waves. We can inject medications that dissolve stones right into the ureter. We can use laser or ultrasound probes to dissolve the stone. And in some cases, we might have to go in and do surgery to surgically remove the stone. there's something else I want to say about stones, but it's not quite coming to the surface here. Oh, I know what I want to say. Despite the fact that 75% of stones contain calcium, calcium restriction is not usually a treatment. It changes your calcium balance and actually leads you to be more likely to form more stones. So typically people are not on a calcium restriction unless they have a very specific issue with their calcium balance. Okay, lower urinary tract obstruction, all kinds of things can cause this. Poor muscle control at the bladder neck, enlargement of the prostate gland, a stricture of the urethra, pelvic organ prolapse, tumors, neurogenic bladder, so the detrusor muscle doesn't work. And up here we have bladder neck dyssynergia, and down here bladder sphincter. So either place, if the neuromuscular function of those sphincters or muscles isn't working, we can get obstruction. Prostate disease, benign prostatic hypertrophy or hyperplasia begins in most men around 40 to 45 years of age. We see it pretty universally. We know if men live long enough, they're going to see some degree of BPH. Testosterone, a hormone that everybody has, not just men, but it's acted on by an enzyme called 5-alpha reductase to convert the testosterone to DHT, and the DHT is what stimulates prostate enlargement. So they're looking at all kinds of reasons why this happens. We know it happens, we can't always pin it down. But the balance of androgens and estrogens, so men have estrogens as well as women, just like women have testosterone as well as men. And some of those growth factors that we've mentioned in previous discussions. So the American Urologic Association has a questionnaire to help assess the symptoms of BPH and then to classify the severity of the disease. So we would ask patients over the past month, are they having problems urinating, finishing urination? Do they have problems with dribbling? Do they stop and start several times? Do they lose urine? Do they have some incontinence? And then have they had to get up at night to go to the bathroom? And they get a score depending on how often they do that. So the score tells us the severity of the problem. And the higher the score, obviously, the more severe and the more likely we are to intervene for the patient. So some common medications that are used, we can give medications that inhibit that 5-alpha reductase. So we have less production of that DHT, which is the form of the hormone that contributes to BPH. And a common drug there is finasteride or Proscar. We can also give alpha adrenergic blockers. Now, if you see those in cardiac units or in patients that have hypertension, we see those because they block, well, let me start over here. Alpha receptors in the blood vessels cause vasoconstriction. So if we give alpha blockers, that dilates blood vessels, so they're used for treatment for hypertension. But in this case, there are actually alpha receptors in the prostate tissue itself, and so alpha blockers help relax the prostate tissue. So that can help reverse symptoms. And it's interesting how drugs are named, you know. So there's a whole class, you know, like, oh, somebody help me with the blood pressure alpha blockers. Doxazosin, prazosin, there's a whole bunch of them that end in OSIN, all alpha blockers. But when we're using the same drug for a different purpose, we have to give it a fancy name like Flomax, having to do with the urinary symptoms. You could give Flomax to somebody with high blood pressure, probably help their blood pressure, but that's not the form that we use. We use Flomax for the people that have BPH. And then saw palmetto is a natural substance, alternative therapy that's used. And there has been some research that suggests that it can help symptoms in people with BPH. It's one of the few complementary and alternative therapies that has some evidence base to it as being effective. So let's stop there and take a break. And we'll come back in 10 minutes.